All right. I think we have over 50 people, or very close to 50 people, so we're going to get started. I want to introduce Nicole Timmerman. Everybody on this call at one time last year met Kelly Porcalo. Nicole has graciously joined MOQC. Nicole comes to us from Michigan Medicine, and she's an advanced nurse practitioner. She worked in the surgical services area of Michigan Medicine and has decided to take a little bit of a change in direction with her career and is now going to be part of MOQC. So she is my wing person on this breakout session. And so she and I will be sharing a little bit of the literature about cancer care in times of COVID. And we'd really like you also to share how you are finding cancer care in times of COVID. So let me just progress here. So our goals for today are, what we'd like to do with you is to really outline what you see as the major changes that have happened with the advent of COVID. What have you found with those changes as being positive for your practice or for the organization that you're representing, and maybe not so good with for your practice? And from that, where do you think you as your practice should go from here? And then from that, where do you think MOQC can help? Because what we would really like to see as a goal coming out of this meeting is maybe one or two things where you think MOQC could sink their teeth into, and from a resource perspective, provide you with some tangible outputs. So say six months from now, based on what list we generate from here, we actually produce something that can be very useful to your practices. Any questions? Okay. Please feel free to take yourself off mute and ask any questions as we move forward. So this is January 15th, and it was almost to the week that Santa Clara County in California documented the first case of COVID. And then the next case was identified in the area outside of Seattle. So it's, and then of course, things blew up from then until we started to experience cases in Michigan starting in February until we got to March 23rd. And it was March 23rd where the governor issued the first what I would call the first lockdown and the work from home mandate in Michigan. So what Nicole and I would like to hear from you is just to organize kind of our thoughts. And I'm going to type these things if I can, just to kind of help us, the group, keep track of all of your ideas, is to hear from you what has changed for you and in your environment in terms of your practice. What's changed for you since that time with your patients, and then what's changed in terms of your clinical teams and the interactions that you've had for your teams. And this is really, we'll run it very much like a brainstorming session, but it isn't brainstorming. We just want you to throw out for us, like what has changed for you. And these are our buckets that we'll just kind of we'll just organize what has happened. Okay, so I'm just going to type so that you can see it, but I'd really like you to unmute yourself and tell us what's changed for you. we'll probably do this for the next 5 or 6 minutes, okay?
Hi,
Who wants
Louise.
to start? Mhm.
Hi, Louise. It's Nancy. And
Oh,
so,
hi, Nancy.
how are you?
I'm good.
Good. So I'd like to, for Dr. Roy and I in Mount Pleasant, what has changed for us, I think, honestly, is the advent of telehealth and how
Okay.
we had to institute that very quickly.
Okay.
And I think I can speak on behalf of Dr. Roy. He doesn't find that appropriate care for oncology patients, and the ability to have a family member present with them and the visitation limitations that were put in place, right, coming into the cancer center. So I think it's really changed how we, not the compassionate care that we give, but how we have to deliver the care. And it's not without its challenges. And Dr. Roy, I think I heard you say you selected this breakout session. Are you on?
Yeah, I'm on.
Yeah, would you like to share with Louise and the team some of the frustration and the disconnection?
With cancer care is you have to examine a patient. You cannot do telehealth through a TV or through a smartphone. A patient needs to be physically examined, a patient needs to be seen, and then appropriate treatment be given.
Yeah.
I can understand in primary care with patients with high blood pressure or some other situations, they can do that. But I do not think that telehealth is appropriate for a patient receiving chemotherapy, receiving treatment.
Okay. Thank you for that.
Hi, Louise. This is Donna. Could I comment on that?
Yeah, sure.
So working in the clinic, we have found in our practice, Dr. Roy, I'm an oncology nurse in Michigan Medicine at our offsite location. And with our, maybe it's the patient population, melanoma and urological oncology, these patients actually appreciated the fact of the telehealth and not having to come into the clinic. So I would say our providers probably had a more positive response to telehealth once people understood how to use it. I mean, there was a learning curve in the beginning, but once people were on board, it wasn't that every visit was telehealth. They did come in, maybe every second or third visit, but our patients seem to like it.
Okay.
Hey, it's Adam Foreman from Providence. I just wanted to add that we used a lot of telehealth also. Telehealth is great when you're just socializing with the patient. When it's a long-term follow-up and there's no new issues and the patient has recent imaging and everything looks good and it's a very standard visit, telehealth is fine. But anytime there's a serious issue with the patient or
You're cutting out a little bit, Adam.
I'm sorry, I'll try to get on a better thing in a second. But anytime there's a serious issue or treatment has to be changed or there's a change in the scan, there's really something lost in translation versus having the patient be there in person. And I think that's a major limitation, that I don't feel comfortable changing a patient's treatment or giving them bad news over telehealth. I just don't think that there's a certain lack of humanity in that I think really gets lost.
I would also echo what you said, and the problem we've had has been the prioritization of our medical assistants in terms of who to see and who to put on telehealth and who to examine. We have clinical trial patients that we are practically obliged to do. And so the other issue, of course, are the MAs making decisions without our input, and whether that's administrative, issue or not. I have, a lot of angst about leaving those kinds of prioritizing patients where they should be, telehealth or face-to-face.
Okay. So it's setting priorities.
So and I think patient identification is what it really comes down to there, is identifying the correct patient for that service.
Okay.
So I would say we had a lot of patients that we put onto telehealth up front. But the one thing that we absolutely never stopped doing was seeing patients. And so one of the things I recognized early on in this is that we were pretty much in our huge building that we are in, which is a multi-specialty practice building with private and employed practices, all sorts of other practices, pulmonary, you name it's in our building. We were the only ones still seeing patients. We were the ones seeing patients because we needed to be there. And there was a point in time where patients really recognized that we were the only ones available. So a lot of the calls that we got were outside of the scope of oncology, a lot of primary care type questions because the patients couldn't get a hold of their primary care doctors and they weren't available for them. So it was one of the things that I recognized that is probably one of the nicest things that came out of it was just an absolute gratitude from patients to us for still being there and being available to them. And they recognized that, especially in the early times, we were at risk. But in spite of that risk and fear, we stayed available for them. And there was such an absolute gratitude and also a genuine concern that was constantly voiced for us and for our safety for my entire staff. And so in many ways, I found that in the beginning part of this, that our patient population did everything they could to uplift us in such an amazing way. And it made going through these challenges so much more, you felt so much more appreciated, and it really made it feel so much more worthwhile.
That's really nice, Dawn. Okay, thank you. So
This is actually, can I give a comment, please?
yes.
Okay, so telehealth is a very good tool. So it's good or bad, depends on how we use it. I personally liked it or hated it. It depends on what situation. We have a lot of rural patients. Sometimes, like in the bad weather, like 2 weeks ago, we had this bad snowstorm in West Branch. So patients really liked it. I offered them the opportunity of televisit. So they really liked it. Mm-hmm. However, on the other hand, there's a lot of bad internet service up in the remote area. The televisit, especially the video one, is terrible. The connection is very bad. You get cut off every other words. So in those situations, it's a really bad options. So really, how do you use it depends on the situation.
Okay. So what would you like? Should we put that under practice, Dr. Liu, and say, like, it just depends on the situation?
Yeah, yeah.
Okay. So,
I had the exact, sorry, I didn't mean to interrupt, Louise.
No.
I had the exact same experience. It was very dependent on their internet connection. Yeah, same experience here. It could be nice but with a bad internet connection, bad Wi-Fi, it was not nearly as good.
Okay, so go ahead.
This is Jothan Rana from Michigan State University. So one of the benefits I found was the ability to connect family members during a conference where perhaps, they're out of state, unable to come into the office that day.
Yeah.
Opportunity kind of to utilize that to have daughters, sons, siblings involved in the conversation as well. The other utility was chemo teaches, where we could do those remotely and didn't really necessarily have to bring the patients in for those visits as well.
I would also add that the limitation in face-to-face of a family member that is unable to come with the patient but stay in their car and the patient's ability to recall the problems that have happened because, you know, they don't have the memory and concentration of that. So that's a negative that, and I echo the sentiment that the telehealth allows us to get family members to actually be there and see us and actually tell us more about their loved ones that we didn't see. So just a comment.
Okay. So how would you like me to represent that, Ernie? Under what category?
I would put that as, you know, practice and patient both, because, you know, as much as you'd like to query the patient face to face, they are really unable to tell you everything because they always relied on a daughter-in-law that took them to the office every time, but they're not allowed to, depending on the policies that are generated from within. So I think you can put it both as a positive for telehealth and a negative for face-to-face, but it's a practice and a patient perspective.
Okay. So my question is, beyond telehealth, which was clearly a big change for all practices, were there any, and we've already heard from Dawn where she talked about the maintaining the face-to-face care, which I know many of you still did, and probably seeing like the gratitude that Dawn spoke about, and patients being maybe more expressive of and worried about you as providers and a clinical team, because you're really putting yourself, it was more visible to your patients that you were really at risk. Was there anything else that anything else that you changed or that you went through in the past year as a result of COVID? I'm not undermining what I've just said. These are significant changes that you've dealt with within a year. But I just want to see that did we miss any other big thing before we move on?
Hi, Louise, it's Donna. I wanted to share that for some of our patients that were coming in, say for treatment or inpatient visit with the provider, they would downplay their symptoms and bypass screeners by saying no. And we had a number of patients that once they were in the clinic setting and the provider was in the room, they actually had more symptoms of COVID and were tested and were actually positive. So I think that patients were fearful of not being able to receive their treatments because of COVID.
Right.
This is Jackie Robertson. I would add to that from Henry Ford Allegiance. In the amount of work that we went into being sure that we provided a safe place for all, the patients here as well as all of the staff, there was astronomical amount of work that went into understanding, you know, all of the screening, but then calling ahead and then reminding them about visitor policies and then identifying if a patient could have a visitor at every visit because of some of the reasons we've already heard. They didn't retain the information or they had physical assistant needs, and then tracking, how do you know that visitors are always approved without asking every time or getting lax and letting too many people in the building? So I would say between even visitor tracking and approval versus COVID screening and then finding out your patient needed to be sent for a test, to then chase down that test result, to then decide when can they come back to the building, to then a whole nother level of improvement in symptoms. So somebody would need to call to be sure they truly met criteria to return. It has been an astronomical amount of work and super impressive.
Okay, that's a really good point. So let me just paraphrase it again. So there was all this additional work about the screening and the testing, which I agree was much more time intensive than we ever did, like during flu season and all of that. But in addition to that, I think there's this other side of the equation that now we had patients that did not want to come in at all. And there was a higher symptom burden of patients at home, and they weren't always upfront with you about their high symptom burden. And then there may have even been a subset of patients that would refuse or may not lie to you, but may try to not answer questions as directly as they should. So there would be delays in care because they were fearful about coming in to receive care. So that could be anywhere from testing, like follow-up on testing, to even infusions. They just didn't want to come in. Am I capturing that correctly?
You are,
Absolutely.
from my perspective, absolutely, Louise. That's exactly what happened.
And yes, I would echo that with the additional amount of
so that's a huge burden on you on us. Correct. Okay, great. So I'm just going to move on because I think we could talk forever on this topic. Okay, so that certainly captures 3 or 4 huge areas of implications for you over the last year. So for those changes, I'm bringing you to my implications for you. So I hope everybody recognizes who this is, or I don't think everybody needs to have white hair to know who this is. Who would like to?
Clint Eastwood.
Very good, Ernie. Okay, so I put.
Badly ugly.
Hey, even better. Who said that?
Roy.
Dr. Roy. Thank you, Dr. Roy. Yes, the good, the bad, and the ugly. So that's Clint. This is Clint from this movie. So
That's telehealth too.
yes. So anyway, so from all of these changes, you've already started to talk about this a little bit. So there were some, it's like there's a crisis
and hear anything.
Oh, I apologize. Can you hear me now? Cleo, can you hear me?
I can hear you, Louise.
Okay, great. So we should never let a crisis go unused, as one CEO told me. Crises are only come around every so often, and sometimes we should take advantage of them. So there are some good things that have come out of COVID. And sometimes we have to look hard for them, but you've already identified some of them. So there's one thing I heard from the previous slide is that there's a good side to telehealth. So there are some advantages for accessing family members who may be geographically not with their family, and they could be part of the call. The second piece is it removes the geography. So we know that sometimes it's a real burden to bring patients into the office, and this removes that. The third piece is that, like Jennifer Temmel said today, some people have really gravitated to online visits and really appreciate them. The fourth piece, and I think this is probably the best piece, is finally it did move the government to reimburse practices and hospitals for telemedicine visits. And they did it so well that when it came out, we didn't even have to have HIPAA compliant technology. But of course, we had to eventually put in the positive technology, so HIPAA compliant technology. So there were some positive pieces. There's been some negative pieces to this. So there are some negative pieces to telehealth. There's the issue about some people not being able to manage the telehealth components. I definitely know people that no matter what you do, no matter what training you do, no matter how well you do your patient portals, this is not going to work for them. The negative pieces are the delays in care, and that's been borne out in the research, both published in New England Journal and JAMA and in Journal of Clinical Oncology, and that there's definitely delays in care. There's even been, and I can send it to you, some recent stuff that has come out of California, and that still continues through today. And then there's stuff that I think from the good, bad, and the ugly, as we would say. So we've talked about the good and the ugly. And then there's probably stuff, the good, the bad, and the ugly is probably what we still don't know we're going to end up doing. And would anybody have a hazard to guess what we still don't know is going to play out with COVID? So, like, do we see that, like, we probably still don't know how much CMS is going to pay for telehealth. So we know that the genie's out of the bottle and CMS is going to pay for telehealth, but we still don't know. They haven't come down and said that, you know, you do have to see an oncology patient at least once or twice during a certain period of time, or once they're a survivor, you must see them like at least once in the office, you know, once every 2 years. So, you know, most times Medicare is slow, but they're not stupid, and they will come out with some parameters like that. So we don't know yet what they're going to come out with, but they haven't, but they will come out with something.
Well, I think one of the things we don't know is what are survival rates going to be relative to cancer impacted by COVID. So what we don't know is, did a patient go on to hospice sooner because they were that afraid of taking treatment during this time period where they may have lived a longer period had they taken treatment? What we don't know is if we had what percentage of our patients died because of COVID that would have otherwise lived. You know, what we don't know is its impact on our statistics yet.
Exactly. I'm going to put this here.
And the other question we don't have an answer to is what it's going to mean now that the vaccines are available to our patients. And that is really a big question. You know, is it truly safe on patients on chemotherapy? What would be their relative risk? How about patients on immune therapy? How are they going to respond once these vaccines get rolled out? Those are the questions that I'm getting asked every day that I really don't know, and I would love a better answer on, because clearly those patients were not included in clinical trials of healthy people.
Exactly. So to kind of help along here, you've already done a lot of this thinking, but we just organized it a little bit for you. You're absolutely right. So good things are, we know at some point that we'll be able to control the virus. The fact that we just have done well with just putting out a vaccine is positive. And we do have an effective vaccine, but as Dawn said, we really don't know the implications of that. We've already have shown ourselves through research that we can treat cancer patients with COVID. And also the cancer research has shown that our cancer patients are not dying of COVID. They're actually continuing to die of cancer, which means that we are really well managing our COVID, the symptoms of COVID. So whether or not patients catch COVID, we have to remind our patients that we have to continue to treat the cancer, because if they get COVID, it's going to be the cancer more than likely that is going to be is most life-threatening for them, not the COVID, because that's what the research is showing us. We've already talked about the virtual visits, but what is negative is already what we talked about. The other piece, though, that we haven't touched on, and I just want to touch on, is there's a lot of anxiety within your patient populations, and you see it every day. And the whole issue about grief rituals and support has been lost for patients and families. So that's a real gap. And I think our hospices are seeing that. And I know that a lot of you, especially if you're on consult service and you're supporting families then, and your own patients, if they're in hospital and they die in hospital, that's been extremely problematic for families. It's a little better with this phase of care because there's been some better support in having some type of funerals or grief ritual, but it's been still very problematic for families who are losing their loved ones in hospital, and if they happen to have COVID, in addition to cancer. Okay, the last piece that is still unknown as well is what they're calling the long haulers. So these are very much like Dawn said, they can be a survivor of COVID and have cancer in addition to being a survivor of COVID. And now you're treating these long haulers who have symptoms. And some of these symptoms are very much like symptoms of cancer treatment, but they are maybe a symptom of their COVID. And these are patients that really nobody really knows anything about. They're just starting to collect data on these patients, and they can have a myriad of symptoms. And so anywhere from lung to motor, skeletal, muscular to neurological, and people really have no clue what to do with them. So that it can be really impactful. And then the last piece is, and it's no surprise to anybody. Yes, is there a question? Okay, the last piece is anybody, as you guys, I'll realize all of you as practitioners know that there's always been disparities in cancer care. Anybody that is impoverished has always experienced delays in care and has always experienced been disadvantaged in terms of survivorship in care, in cancer care, less been disadvantaged. And the research with COVID has only heightened that awareness. So the issue will be is, can we do something about that now, given that that has been made more visible with COVID? Okay, any questions related to this? Okay, yes. Yes.
A couple of practical things. I'm of a small demographic that's still practicing full-time and is of Medicare age.
Yeah.
And so my practice made the decision early on that I was going to physically stop going and seeing patients at the hospital.
Yeah.
Maybe I deluded myself to think I was safer in the office because I maintained a full-time schedule in the office, but at least could control the environment here. And I don't know how other practices handled that. The other thing is in training new physicians, probably 6 months a year, we'd have medicine residents in our practice, but they were taking call in the hospital. They were in the ICUs at the hospital. So we started limiting access to residents to our practice because we couldn't account for where they were. We couldn't do, contact tracing on where residents were and who they were exposed to, and we didn't want them exposed to our patients in the office. There are some other practical implications to this.
Correct. So I'll need to add that to this list.
And also, I typed it in the comments, but I had quite a few patients who lost their support person to COVID. So here they are on their cancer journey and their son died of COVID.
Yes.
It was an awful experience.
Yeah. Definitely. Definitely. And I think that those are big gaps, and we don't have a way to fill them as easily as we would if we weren't experiencing COVID. So basically, what we need to do is, where do we go from here, knowing that we have these positive pieces, we have these really negative issues of COVID, and then we have this big unknown. So it's like being in a car, and it's like the way the way I drive, it's like you kind of have the positive pieces and you know where you're going. So you want it, your endpoint, you have a road, and exactly how to get there. And so you just, follow your roadmap. And then you have, where you want to go. You may not have a map, but directionally where you want to go, and you have some experience about how to get there, and you can make some pretty good guesses. And so you want to maintain your way to go there. But then there's this other part where you're totally clueless, and you're clueless because we have this big bucket of we don't know anything about it, or it's really negative, and we know we have to try to either improve it or try to at least mitigate it, but we really don't know where to start. So I was wondering if maybe we could throw out some ideas about what we know we need to do, or using good guesses, what we could put in under our good guesses, and then what we should put under clueless, because we have to just either stay away from it, or we're not expert and it's really not in our bandwidth, and it's not, it's not for us to deal with because it's not in our scope. So this is really kind of getting us to a list of what we should kind of focus on. And maybe you have figured it out in your practice and you know what to do and you need to continue it. And maybe somebody else in another practice hasn't figured it out. So does anybody want to throw something out that you're doing well and you're going to continue it because you've mastered it in the last year, or you have a gap and you're going to address it, because it's not going to go away.
So I feel like our practice has mastered telehealth and triaging who goes on it. So
Great.
It's been enough months, but I think immediately getting patients to get their vaccines, who gets them, having literature on that for educational purposes for not just the patients, but I think for us too, that's an immediate need. And I think I have some good guesses on how to give it, but I really would like more clear direction, both for myself and I think for the patient population, for them to be able to make informed decisions on it.
Got it. So is there a particular vaccine or just generally like how to talk about the vaccine, Dawn?
I don't think it's one in particular. I mean, we're probably going to give out Pfizer simply because we're in Michigan, it's made here and we've got the freezers, but that's us. And I don't think that applies to the whole state. So right. I wouldn't I wouldn't make it a particular vaccine. I just think vaccine in general, patient population, and really depending on what they're receiving. Chemo, what's the timing? What's the best timing for them to get it? Where do they go for it? I mean, there's a lot of questions that are still up in the air. You know, an example, I have a patient who's getting it, and I'm sure Henry Ford will be able to give him it. His caregiver is under the age of 65 and is not employed by a healthcare system, but she works. And when she tried to get it through the state, it's looking like April for her. That's ridiculous. So those are the things that I think we still need to figure out.
Got it. Okay.
Yeah, this is Rana Belbasi from Carmanos Macomb. Carmanos put out like this memo with like a very specific policy about individuals who, if you're on chemotherapy, they weren't very specific about that, but if you're on chemotherapy actively, then 2 weeks after your last dose and 2 weeks before your next dose, you can get the vaccine. And then they went through all of the immunotherapies and said everyone else basically can get the vaccine whenever they want. But there was no literature that came with the memo to even explain where they're coming up with this policy. Yet they sent it to everyone in the entire Carmanos network, that's what we're supposed to be telling our patients. So, you know, that probably is a good guess, but, you know, the problem is that, you know, they didn't specify, is this just IV chemotherapy? Is it just people who are going to get immunosuppressed from chemotherapy? I mean, I have people on 5FU that have normal, you know, neutrophil counts. I mean, who are they referring to? I've got people who are immunosuppressed on immunotherapy. So even though Carmanos put out this policy, it's still a concern because there really was no literature attached to that to give us any sort of, you know, any sort of guidance with that.
And I think the other problem is the logistics of that. So if you're saying that, and this is where I struggle, if I'm saying that I really want you to get it right before you're due for chemotherapy or 2 weeks after your last dose, I can't even get them scheduled. I mean,
Yes, absolutely. And then they're stuck. Most of our chemo patients are either on a 2 or every 3 week schedule. So we're having to push back treatments, or we're having to tell them, well, then you're just going to have to wait till you're done with chemo if you're adjuvant. And if you're metastatic, well, then we're just going to have to, you know, push things around to accommodate the fact that, you know, the Moderna vaccine is every 4 weeks, the Pfizer one's every 3 weeks. That means you have to have gaps in between treatments in order to accommodate that.
Got it. Yeah, the scheduling, I've just experienced here, and it's not easy, and I'm not dealing with all of these other issues that, like personally, that you guys are dealing with all of the variations in your patient population. So, okay, that's a good, those are very good examples. Does anybody else want to give some input? Yeah.
I mean, one question
really
is,
good ones.
Once we're all vaccinated, when can visitor policies change?
Okay.
You know, once some patients are vaccinated, you know, I think this is a big problem both in the hospital and in the clinic. You know, right now we have a no visitor policy in the hospital, and it's really detrimental. But once the health practitioners are vaccinated, you know, when are we going to go back to normal? When are we going to stop wearing masks? I think these are unknown questions, but hopefully soon.
Yeah, I have no idea. I haven't read anything or seen anything about when masks will ever be removed. But definitely, I don't know of any hospital that has a no visit. I mean, I think everybody has a no visitor policy right now with their.
Carmanos allows visitors.
Oh,
and,
great.
You know, that just throughout this whole time, the lack of visitors for dying COVID patients is, I mean, if you ask me, is horrible.
Mm-hmm.
You know, where they're not allowing family members to sign a consent form that they can see their family members and they understand the risk. I think that's a nightmare, and I think that's a abhorrent policy that people have. And you know, these things need to change because you know we're not going to stay in masks forever. I think this is something that has to start being discussed as we vaccinate the bulk of the population in the next 6 months.
I think the policy will only change when the case load gets less and less in the states. I don't think anything to do with vaccination.
Yeah. I will tell you, so is there someone from I'm just looking, I'm sorry. Is there someone from Carmanos at here? Noreen, you're here. Is Carmanos allowing visitors for a dying patient or no?
This is Patrice I'm on and
Oh,
Noreen.
Patrice, thank you,
Yeah.
Patrice.
For dying patients, we have, yes, we have. We are allowing visitors for new patients when they come in for their first consultation with the oncologist, the surgeon, and the radiation oncologist. So we do want a family member with them because we know that there's a lot to absorb and you need a second set of ears. So we do allow that. We have tried doing for other visits FaceTime with the visitor outside, but there are limitations to that. But
Right.
for the dying patient on the inpatient side, yes, for the dying patient, we do allow 2. Is that right, Noreen? I don't know where Noreen went, but I believe it's 2 because we also know that the person who's with the patient needs support also. So I believe that's how.
This is Vera.
Oh, yeah.
It is 2.
Yes. So
Okay.
so it's very limited still, and we don't, we're not, we wish it was more. We know the importance of having family present during patient interaction or in patient care. We honestly, we've also seen an uptick in our harm events for patients. We're looking at data across the state, and this is not just true for the cancer patient, but at the same time, there's like sometimes information overload that we're seeing more of the falls with injury, more pressure ulcers, more infections. And we think some of this has to do with that, we don't depend on our family for providing care, but we do, a lot of times they are providing information on the inpatient side. And if the patient isn't providing it, the family can. And so we're just looking at that too. So we do think the presence of family members or caregivers during a patient's hospital stay, clinic visits, infusion visits, all that is helpful. And we want to get back to allowing that.
Okay. I just wanted, if you do that, I do know that Michigan Medicine, you're correct. Their visitor policy right now is no visitors, but they do allow visitors for patients that are dying. And that's a change from the March, June time period when COVID was, we had higher COVID numbers on the inpatient side. So I just wanted to let people know that. So there are a few hospitals now that have changed their approach to patients and families for those that are dying, as opposed to what was in place in March. And if anybody needs a copy of the Michigan Medicine policies, I can provide them to you. But that doesn't mean that your particular organization will adopt them. So I do realize we're over 1 o'clock, so I'll just move on. But I have heard from you that I think that we could take some of your ideas and at least look at some of the resources that are out there. There's very few, if any, but I think we could at least see what's out there and see if we could put something together in terms of starting something, and you could bring them to your own organizations around scripting for yourselves around vaccines and what to say to patients around vaccines. And we could think about if there's something out there around some guidelines related to more thinking around vaccines and chemotherapy and immunotherapy. I haven't seen it, but I have to tell you that this is not my wheelhouse, but we can certainly spend some time, as opposed to your practices spending time, seeing if we can do some work in that area. Given the time that it is, I'd really like you to think a little bit more about this. And if there's one or two things that you think would be helpful for your practice, please email us, because we would be very happy to spend the time to do the work if it's of value to you. So we can, I call it the ABC method, where MOQC's calling it the ABC method. We can advocate on your behalf. We can build something that you can find useful and that would save you some time, or we could communicate something and build it, communicate something that's pertinent. So if you can use that acronym and send it to us over the next 2 to 4 weeks, that would be great. So thank you for your feedback. I will, these are just a few of the resources that are out there. Many of them you already know, but there are some oncology, these are, of course, oncology specific ones, Cancer Care and Vital Talk. Vital Talk and Cancer Care are both oncology specific. Vital Talk does have scripting for physicians to use with patients around COVID. However, the last time I looked, which was last week, they did not have something specific around vaccines. So I will reach out to them and see if they are developing something. And we will, Nicole and I will spend a little bit more time seeing if there's something coming out related to what has already been discussed today. Just to wrap up so that you can all go and finish off the day so that you can start your weekend. Many of you already know about our spring and fall meetings. You can use this deck to check against your calendars so you can attend your regional meetings. We know our spring regional meetings will be virtual, so unfortunately we'll not be able to have dinner meetings with you, but we're very hopeful that by the fall, we'll be able to see you in person. So we're going to remember that our fall meetings are quality meetings and will be in person. And then we hope that our next biannual meeting, which is in June and will be in Midland, will be in person. That's what we're planning right now. But of course, we are held hostage, just like all of you, to what the state will allow in terms of gathering and what will be safest for all of us. So that date is Friday, June 18th. And then if you are a practice that has a gynecologic oncologist, the next meeting for those physicians, you're welcome to attend, is Saturday, April 10th from 9 to 1. That's a virtual meeting. And then we have our resources, which normally we would have a table of resources. And now you used to have to call us. You now can go online and you can actually order online. This is the first page of this. It tells you the quantity you can order. And we're just getting a little bit more 21st century. So it'll be just a little easier, but you can still call us if you run into problems. Related to our palliative care resources, Dr. Michael Smith, who's a PharmD and has presented before at our meetings, we have now his presentations available on our website, on YouTube. And we do have, we are co-sponsoring a care management webinar on billing for care management. And that's done by pharmacists. And the 2 dates are in February and March. Again, this will all be sent to you. And then don't forget about your CMEs, and here's some contact information. And we have the pieces for you to get your CMEs if you haven't done that with us before. Here's the credit instructions for the pharmacists if you haven't collected CMEs for yourselves or hours, excuse me, as a pharmacist. And then finally our thank you. And I didn't realize just to run you through that would take about 8 minutes. Yes, Ernie.
Will you supply us with a slide deck on what's allowed for the meeting? Like,
what do you mean what's allowed for the meeting?
I don't know whether Dr. Tamo's slides are available to us.
Yes,
and
they are.
Also Jennifer's presentation on the update on MOQC membership, and then the slide deck that you just shared with us, the contact number and all of that.
Yeah, all of it's available to you, Ernie. And so this afternoon, I'll be emailing it to you.
All right.
Does that sound good?
That sounds great.
And then if you can't find something, you know how to call me.
Oh, yeah. All right.
Okay,
Well,
so everybody can go. I mean,
Thank you, Louise. You will be so missed.
All
I
right.
really
Louise.
Okay, take care. Send us some ideas so we can do something for you.